Clinical chemistry, tumor markers. Cancer is the second leading cause of death in developed countries, accounting for 23% of deaths in the United States and approximately 3 million deaths each year globally. Biologically, cancer refers to the uncontrolled growth of cells that often forms a solid mass or tumor, neoplasm, and spreads to other areas of the body. Formation and spreading, metastasis, of tumors is caused by a complex combination of inherited and acquired genetic mutations. During tumorigenesis, mutations activate growth factors and oncogenes in combination with inhibition of apoptosis, tumor suppressor, and cell cycle regulation genes. Cancer is staged based on tumor size, histology, regional lymph node involvement, and presence of metastasis. This is a diagram showing cancer staging and progression. So we start with a localized or primary tumor. Then we have the invasion of the primary tumor through the epithelium and then into blood vessels or sometimes into the lymphatic system. Then we have the migration of the tumor into regional lymph nodes and metastasis and invasion of the tumor to distant tissues. Tumor markers are produced either directly by the tumor or as an effect of the tumor on healthy tissue. Types of tumor markers include enzymes. Levels of certain enzymes correlate with tumor burden. Serum proteins, beta-2 microglobulin and immunoglobulins. Endocrine tumor markers, specific markers of secreting tumors. Oncofetal antigens, carcinoembryonic alpha-fetoprotein, and receptors, non-serologic estrogen and progesterone receptors. The timeline of tumor marker use. So we have the utility for screening, biopsy indication, diagnosis, high levels indicative of disease, prognosis, high levels are associated with poor prognosis, receptor status used for indication of chemotherapy, monitoring treatment, monitor efficacy of chemotherapy, residual disease after surgery, and detection of recurrence, increased associated with relapse. And you can see the tumor marker and its time of utility. Screening. The ideal tumor marker would be tumor-specific, absent in healthy individuals, and readily detectable in body fluids. Numerous tumor markers have been identified that have a high enough specificity and sensitivity. Tumor markers are used in combination with clinical signs and symptoms and histology to facilitate clinical decision-making. Few tumor markers are used to screen populations, except for prostate-specific antigen, or PSA. Susceptibility to cancer can be determined using molecular diagnostics in patients with breast, ovarian, or colon cancer by identifying germline mutations in patients with a family history of these diseases. Breast and ovarian cancers are associated with germline BRCA1 and BRCA2 mutations. Colon cancer with adenomatomatous polyposis coli gene, APC. Prognosis. Tumor marker concentration gradually increases with tumor progression, reaching its highest levels when tumors metastasize. Tumor marker level at diagnosis can reflect the presence of malignancy and aggressiveness of the tumor to help predict the outcome. Monitoring therapy effectiveness and disease recurrence. After surgical resection, radiation, or chemotherapy, tumor markers routinely followed serially. In patients with elevated tumor markers at diagnosis, effective therapy results in dramatic decrease or disappearance of the tumor marker. Many tumor markers have a lead time of several months before disease would be detected by other modalities, allowing for earlier identification and treatment in cases of relapse. Lack of standardization makes comparison of serial patient results using different assays treacherous. Differences in antibody specificity, analyte heterogeneity, assay design, lack of standard reference material, calibration, kinetics, and variation in reference ranges. Tumor markers can vary widely between reagent lots. This is particularly a concern where polyclonal antibodies are used as reagents. Tumor markers often vary in concentration by orders of magnitude, making accurate measurement challenging compared with routine chemistry analytes. So we can't compare patient to patient with tumor markers. We can only compare serial draws from the same patient. Immunoassays are most commonly used method to measure tumor markers. They have many advantages, including the ability to automate testing. Factors in interpreting tumor marker immunoassays, linearity, hook effect, and heterophile antibodies. Linearity, determined by analyzing in replicates specimens spanning the reportable range. The linear range is a span of the analyte concentrations over which a linear relationship exists between the analyte and signal, measured by analyzing specimens spanning reportable range. The hook effect, when analyte concentrations exceed the analytical range excessively, there is a potential for antigen excess. Capture and label antibodies are saturated, resulting in a lack of a sandwich formation, resulting in a decrease in signal. The name hook effect refers to the shape of the concentration signal curve when the reagents are saturated with excess antigen. Samples exceeding the linear range should be diluted and retested. Heterophile antibodies, circulating antibodies against animal immunoglobulins, can cause significant interference in immunoassays. They occur in patients given mouse monoclonal antibodies for therapeutic reasons or who have been exposed to mice. High-performance liquid chromatography is commonly used to detect small molecules. Most widely used method to detect catecholamines and their metabolites in plasma and urine. Analytes of interest are separated from plasma or urine, run over a column, and separated by physical characteristics. It's used to detect neuroblastoma, pheochromocytoma, carcinoid tumors. Neuroblastoma is diagnosed by the detection of high levels of plasma epinephrine, norepinephrine, and dopamine. Pheochromocytoma, a rare tumor associated with hypertension, is diagnosed by detecting elevated plasma metanephrines. Carcinoid tumors are serotonin-secreting tumors that arise from the small intestine, appendix, or rectum. Tests immunohistochemistry and immunofluorescence test tumor markers that are detected directly within solid tissue. These are identified in tissue sections, typically from fine needle aspiration or biopsy samples. A slice of the tissue is placed on a glass slide and incubated with the specific antibodies in solution to detect the presence of antigens. Example of the use of a tumor marker that is detected by immunohistochemistry is the identification of estrogen and progesterone receptors in breast cancer. Enzyme assays. The detection of elevated circulating enzymes generally cannot be used to identify specific tumor site or site of tumor. The exception is prostate-specific antigen, or PSA, that's found exclusively in diseased and benign prostate glands. Before the use of immunoassays in oncofetal antigens was common, enzyme detection was widely used. Examples of enzymes as tumor markers: alkaline phosphatase, bone, liver, leukemia, sarcoma, creatine kinase BB, CKBB, prostate, small cell lung cancer, breast, colon, ovarian cancers, lactate dehydrogenase, liver, lymphomas, leukemia, and PSA for the prostate. Alpha-fetoprotein, an abundant serum protein synthesized by fetal liver and re-exposed in certain types of tumors, often evaluated in patients with hepatocellular carcinoma and germ cell tumors. Regulation or physiology, a 70 kilodalton glycoprotein related to albumin, normally functions as a transport protein and is involved in regulating oncotic pressure in the fetus. The upper limit of normal for serum AFP is approximately 15 nanograms per mil in adults. Clinical application and interpretation. AFP is used for the diagnosis, staging, and prognosis and treatment monitoring for hepatocellular carcinoma. Also used for the classification and monitoring therapy for testicular cancer and for tumor staging. It's measured by a variety of immunoassays, commercially available automated immunoassays. These are typically sandwich immunoassays relying on monoclonal or polyclonal antibodies directed toward different regions of AFP. Cancer antigen 125, CA125. It may be useful for detecting ovarian tumors at an early stage and for monitoring treatments without surgical restaging. It's expressed in the ovary and other tissues of Müllerian duct organ and ovarian carcinoma cells. Only clinical acceptable serological marker of ovarian cancer. Immunoassays using OC125 and M11 antibodies. Carcinoembryonic antigen, or CEA. CEA was discovered in the 1960s and is a prototypical example of an oncofetal gene. It's expressed during the development and re-expressed in tumors. Most widely used as a tumor marker for colorectal cancer, also elevated in lung, breast, and GI tumors. Large, heterogeneous glycoprotein, molecular weight of approximately 200 kilodaltons, part of the immunoglobulin superfamily, and is involved in apoptosis, immunity, and cell adhesion. It's a tumor marker for colorectal cancer and used for the prognosis, post-surgery surveillance, and to monitor the response to chemotherapy. Historically used by polyclonal antibodies, now uses monoclonal anti-CEA antibodies. Due to the high heterogeneity of CEA, it is essential that the same assay be used for serial monitoring. It is not recommended for screening asymptomatic individuals for colorectal cancer. Human chorionic gonadotropin, or HCG, is a dimeric hormone secreted by trophoblasts in placenta to maintain corpus luteum during pregnancy. A 45 kilodalton glycoprotein consisting of alpha and beta subunits. Its clinical application is the prognosis of ovarian cancer, the diagnosis of testicular cancer, and it's the most useful marker for gestational trophoblastic diseases. Immunoassays with monoclonal capture and tracer antibodies. Prostate-specific antigen, or PSA. A 28 kilodalton glycoprotein produced only in the epithelial cells of acini and in prostatic ducts. Regulates seminal fluid viscosity. Dissolves cervical mucus cap, allowing sperm to enter. Regulation. Low levels of PSA can be detected in serum of healthy men. Two major forms found circulating in the blood, free and complex. Prostate infection, irritation, and BPH enlargement can result in increased PSA. Use of PSA to monitor cancer progression has also been found useful after radiation or endocrine therapy. Annual screening of prostate cancer in men over 50 years old and in younger men at high risk or with a family history. Normal range is less than 4 nanograms per mil. Factors to take into account when testing for PSA include age, PSA velocity, free PSA versus total PSA ratios. Methodology, it's measured by immunoassay using enzyme fluorescence or chemiluminescence on an automated immunoassay platform.